Hello guys, welcome back to this NEET-PG recall session. So finally your exam is done now. Okay, you guys are relaxed. I think it was a very difficult exam for you guys. Okay, I have heard that many of you, you had difficulty in reaching your exam centers also, because it was raining in Delhi. Some of your exam centers were changed at the last moment. So definitely a very difficult exam. And coming to this exam, okay, so as many of you are saying, the difficulty level was high, right? The examination was moderate to difficult, right? Talking about the radiology, okay, so radiology, again, it was a good question paper. So examiners are moving beyond the typical signs that are frequently asked in radiology, and they are talking about the MRCP abdomen images, like colorectal cyst, it was asked. So MRCP images are becoming very important, right? Then if I talk about CT aortogram, images are being asked. So an image of aortic aneurysm was given to you. So again, this is again important. Then you have images from the temporal bone, images are being asked. So definitely, if I talk about radiology, okay, the exam was not very simple, not moderate. Yes, it was a difficult exam, right? But given the history, right, things can become a little easy, right? Then images of the fracture of spine, again, I would say a difficult question, right, at your level. So exam was definitely difficult. So let us discuss the questions, right? So talking about the first question, right? So guys, what we can see in this image is that a CCT image of the chest is given to you guys, right? And you have to identify the labeling. So I don't know which part was given to you, so let me discuss with you the important parts. So guys, the structure seen here, this is the arch of aorta. So definitely cross section at the level of abdomen, at the level of mediastinum was always important. Then this is your superior vena cava, a black structure that you can see in the midline. This is the trachea, right? And just adjacent to trachea, this is the esophagus. So these are important parts. If you go at a level above the arch of aorta, you will see the three branches of the arch of aorta, that is your left subclavian, left common carotid, and brachiocephalic. So from right to left, you will have left brachiocephalic, right, then left common carotid and left subclavian artery. So these are the important vascular structures that you should know as far as CCT abdomen is concerned. Then a question was asked, right, about the muffled heart sounds to the right side, okay. A diagnosis of congenital diaphragmatic hernia is established. Simple question, okay. You have been given a diagnosis in the question itself, right? Now you have to make a diagnosis. So guys, most common site of congenital diaphragmatic hernia, right, this is left posterolateral, right? So let us see how does a congenital diaphragmatic hernia looks like. If I talk about the images, again, it was a difficult question, right? So guys, what you will see is that on the X-ray images, you will see multiple cystic areas within the lung, right? So you have to first identify a cystic areas within the lung, right? So the two X-rays that I'm going to show to you, which were asked in your exam, right? So here you can see multiple cystic areas in the lung, right? And in the second image also, image number B, this was also asked. Again, multiple cystic lucencies can be seen. Now guys, we have to see what is the difference between these two lucencies, right? So in the first case guys, we can see that trachea is deviated to the opposite side, okay, whereas in the image B we can see that trachea is midline, right? So when trachea is deviated to the opposite side, what you are going to think of? You are going to think of congenital diaphragmatic hernia, right? But when the trachea is in the midline, okay, you are going to think of CCAM, congenital cystic adenomatoid malformation, right? And one more thing is that in this question itself they had given you gurgling sounds are seen in the thorax, okay? So gurgling sounds are those of sounds of the bowel loops. So in congenital cystic adenomatoid malformation you will not see any gurgling sounds. And one more thing that was given to you, okay, so you can see that this is the CT image, right? So in this CT image also, these are the lung window images. You can see cystic areas within the lung, variable size cyst, so again seen in the cystic lung disease, right? You were given the ultrasound images as well, and on the ultrasound images you can see echogenic lung with cystic areas. Again, these are characteristic of cystic adenomatoid congenital cystic adenomatoid malformation, right? You should know the classification also. Stocker classification system is used for CCAM, right? So a 10-year-old child after a road traffic accident, right? Physical and radiological examination points towards injury to the mark structure, right? So anterior tibial tuberosity was a structure that was shown, okay? So guys, this is the structure, this is your tibial tuberosity, right? So guys, what is Gertie tubercle? All these things are very clear. Anterior intercondylar area, okay, medial tibial condyle, these you know. But talking about Gertie tubercle, it is a smooth facet just along the anterior surface just below the knee joint, right? So this is your Gertie tubercle. So simple question, the structure that was marked for your tibial tuberosity. Another question that was asked on the tibial tuberosity was that a patient presented with pain along the anterior surface of knee, right? What did you see on the X-ray of the knee joint? On the lateral view, you could see that there was irregularity along the anterior surface, right? So this irregularity along the anterior surface of the knee joint, guys, this is characteristic of Osgood-Schindler's disease, right? Characteristic of Osgood-Schindler's disease. Right? And what is Osgood-Schindler disease? It is nothing, it is but your osteochondritis of tibial tuberosity. Right? Now an image was shown to you. Okay, you were asked to identify the investigation, right? So this was a lateral view. Okay, so various views are taken. What you will see an X-ray image, and within that X-ray image you will see that there was opacification of the esophagus by a contrast. So whenever you see an image in which there is opacification of the esophagus by the contrast, so that will be a barium swallow image, right? So barium swallow image is done using fluoroscopy only, right? So if you have to go for a more specific answer, so that would be a barium swallow, right? So multiple views are taken in the barium swallow. You can be given an AP view also, right? You can be given an lateral left posterior oblique view, then RAO view. Multiple views are taken. So this was a lateral view to see the pharynx, right? So we all know barium swallow is an investigation mostly done to look to investigate patients with history of dysphagia to liquids or solids, right? So yes. So you will see a bird's beak appearance, right, in patients with ecclesia cardia, right? You will see a rat tail appearance in patients with esophageal cancer. Then you can also do a barium swallow to look for Zenker's diverticulum, Killian's dehiscence, right? MRI image of a patient is shown to you, right? So these are the post contrast T1 mirrored images, right? So on the post contrast T1 mirrored images, you can see that there is a lesion in the sella and suprasellar location. Okay, the lesion it is showing heterogeneous contrast enhancement. Okay, and if you see the appearance, so the appearance is a figure of 8 appearance, right? So this is characteristic of pituitary macroadenoma, right? So we will call an adenoma as pituitary macroadenoma when the size of the lesion is more than 10 mm, right? Now guys, we need to know what is the kind of visual field defect that we will see in these patients. So if I draw the two orbits, right, and if I divide this orbit into two parts, right, temporal, okay, and the medial part, right, this is the temporal side and this is the medial side again. So the medial fibers, okay, they are going to cross, okay, whereas the lateral fibers, okay, they are not going to cross. They will carry the fibers from the same side only, right? They will travel to the same side. Now what happens in patients with chiasmatic lesion, right, or a suprasellar lesion, there will be pressure on the medial fibers, right? So whenever there is pressure on the medial fibers, what you will see is that there will be loss of vision from the medial side of the orbit. Okay, and we all know that the medial side of the orbit, it is responsible for temporal vision, right? Temporal vision. So you will see there will be loss of temporal vision on in both the eyes. So this is known as bitemporal hemianopia, right? So a similar question was also asked. Okay, again they had showed you a sagittal. So this was a sagittal T1 mirrored image, right? And what you can see that there was a hyper intense lesion in the sella suprasellar location, right? So guys, if a structure is bright on T1 mirrored images, it can be blood, it can be hemorrhage, or it can be keratin, right? So blood and hemorrhage, okay, if I talk about, or it can be fat also, right? So these are the few structures which appear bright on T1 mirrored images. Now the question is, okay, so 15-year-old child, right, there was a suprasellar mass with heterogeneous enhancement, right? If I talk about pituitary adenoma, it is going to show a homogeneous enhancement, right? If I talk about craniopharyngioma, so craniopharyngioma, it has cystic components within it. So cystic components of the lesion, they never enhance on contrast enhanced images, right? So it is going to show a heterogeneous enhancement. And excision of the mass reveals a motor oil fluid. Again, they have given you a very beautiful hint, motor oil fluid, right? So guys, these are characteristic features of craniopharyngioma. Motor oil fluid, then it is hyper intense on T1 mirrored images due to the presence of wet keratin, right? And sagittal T1 mirrored images are given to you, and they can also present with bilateral, okay, temporal hemianopia, right? Homonymous hemianopia, right? Now talking about another question, okay, so what they had asked, they had given you that a patient presented with fever, okay, there is no sign of meningitis, and what we can see that an MRI brain with the diffusion mirrored images was given. So guys, these are the post contrast T1 mirrored images, right? And the second image was that of a diffusion mirrored image. So what you can see on the post contrast, there was peripheral enhancement within the lesion, right? And this lesion, it is showing restricted diffusion. So guys, all these are characteristic features of brain abscess, right? So guys, if I talk about ring enhancing lesions, they can be remembered with a simple mnemonic, that is Dr. Magic, right? So where D stands for demyelinating disease, okay, R stands for radiation and necrosis. So here we have been given an history of fever, okay, it means that it is an infective condition, so glioma is ruled out, okay. Toxoplasmosis, it is seen in immunocompromised patient, right? So toxoplasmosis, okay, and you see typical signs like in toxoplasmosis, what you will see is that there will be eccentric dot sign, right, will be seen in toxoplasmosis. Then you can also see a concentric ring sign, right? So this was typical of brain abscess. In tuberculoma, you may not see a central diffusion restriction, right? And you may not see an isolated tuberculoma, right? So TB meningitis, okay, tuberculoma will be seen in patients with tubercular meningitis. So you will have other features also like basal exudates, okay, then hydrocephalus, Then you can also get vasculitic infarcts. These are the other features that you can see in patients with tuberculosis. So we were talking about the ring enhancing lesions in the brain. So these can be demyelinating disease, then radiation necrosis, then you have metastasis, A for abscesses, glioblastoma, infective conditions like tuberculomas, right? So, and C for cysticercosis, right? So these are important ring enhancing lesions. Now a patient has fever ranging between 101 to 103 degrees Celsius. Purulent sputum chest X-ray was shown below. What can you see on the chest X-ray was that there was a cystic lesion, and this cystic lesion, it was also having air fluid levels, right? So very typical X-ray cystic lesion with air fluid levels. It is typical of a abscess, right? So brain abscess was asked, then another was your lung abscess which was asked, right? Pneumatocoel, guys, you will see a cystic areas, okay, will be seen within the lung, and along with that you will have history of, it is associated with staphylococcal infection, right? You will see a pneumatocoel formation. So either they can ask you the causative organism when they will show you pneumatocoel, right? Talking about empyema, okay, in empyema you will see a very typical appearance, that is the split pleura sign, right? So in this split pleura sign there is enhancement of the visceral as well as parietal pleura, right? And lung abscess we have already seen here, right? Then diagnosis on the CT image, okay. So these patients usually present with history of back pain, right? And X-ray can be the first investigation which will be done in these patients. So what do you see? You will see that there is anterior displacement of the L5 over S1. This is the L5 vertebra, this is the S1. You can see there is anterior displacement of L5 over S1. So guys, this is seen in a patient with spondylolisthesis, right? So what will you see in what is the name of the sign that you see in spondylolisthesis? So it is a dog with a collar sign will be seen in patients with spondylolisthesis, okay. This is due to the fracture of pars interarticularis, right? So this is this kind that you are going to see in patients with spondylolisthesis. Another question that was asked on the fracture, okay, that was a patient with history of road traffic accident. A CT image was shown to you, okay. You have to pick up the diagnosis. So this fracture, this is classically seen in patients with seat belt injury, right? What you will see that there will be a fracture line, okay, that is a transverse fracture line will be seen traveling the vertebra along with involvement of the posterior column. So here we can see that this was the vertebra which was involved. There was a transverse fracture line, okay. There was a little decrease in the height of the vertebra, right? And along with the decrease in the height, what you can see, along with the decrease in the height, you could see that there was involvement of the posterior element, which is characteristic of chance fracture, right? Just anterior wedge collapse. It is seen in patients with tubercular spondylitis. Okay, you will not have any history of any infective condition, right? In old age patients, right, again with history of osteoporosis, mostly females. Okay, there can be history of trauma also, fall. Okay, you can get anterior. Okay, there can be a compression fracture in these patients, right? Compression fracture of the vertebra can be seen, right? Now diagnosis on this MRI image, right? So this is the T1 mirrored image. What you can see on this T1 mirrored image, this is the foramen magnum, and this is your tonsils. These are your cerebellar tonsils, and you can see that these cerebellar tonsils, these are reaching below the these are crossing the foramen magnum, right? So what do we call this condition? So this is nothing but herniation of cerebellar tonsils, right? And this herniation of cerebellar tonsils, this is seen in patients with which condition? Arnold-Chiari malformation, right? Type 2. In type 2, you can also see an associated meningomyelocele, right? And what are the two important signs that you see in these patients? You get on the antenatal scans, you will see a banana sign because of the banana shaped appearance of the cerebellum, and you can also get a lemon sign due to the appearance of the skull, right? So just remember these two important images: banana sign, lemon sign, Arnold-Chiari malformation, right? If I talk about corpus callosum agenesis, right, in corpus callosum agenesis, you will get a racing car sign on T2 mirrored images. Vein of Galen malformation, okay, you will have an history of pulsatile swelling, okay, in the anterior fontanelle, right? You will have features of congenital congestive heart failure, right? And you will see a large flow void, black color flow void on the T2 mirrored images, right, in the region of straight sinus, right? So these are the characteristic imaging features of vein of Galen malformation. And in Dandy-Walker malformation, you will see that there will be hypoplasia of the vermis, and because of hypoplasia of vermis, what you will see, there will be a large posterior fossa, right, will be seen, okay, and you will see cystic areas within the posterior fossa. That will be your Dandy-Walker malformation, right? So another question, okay, a patient, a 76-year-old male patient, okay, presents in a confused state he is on antihypertensive medication, minor trauma due to fall from chair 3 weeks back, and NCCT head is done. Okay, very typical question that is asked in patients with. So this is a case of traumatic brain injury. Most common investigation is NCCT head. So if you find a concavo-convex shaped collection, what you are going to think of? You are going to think of subdural hemorrhage, right? So this subdural hemorrhage, this is mostly seen in patients with old age, okay, in patients who are alcoholic, right? And injury is usually trivial, okay. So even a minor traumatic injury, it is due to the rupture of cortical bridging veins. So in old age patients, what happens? These veins, these are already stretched out. So these stretched out veins, these are very prone to rupture, and even a minor trauma to the head, it results in injury to these veins, right? Now another very good image based question, okay, presents with pulsatile tinnitus and hearing loss. So you guys can make a diagnosis on the history only, right? On clinical examination, reddish color mass was seen behind the promontory of just adjacent to the cochlear promontory. So what is the CT showing you? CT is showing you a soft tissue lesion just adjacent to the this is the cochlear promontory, okay. So we can see a soft tissue lesion adjacent to the cochlear promontory. So this is characteristic of glomus tympanicum, right? Soft tissue lesion adjacent to the cochlear promontory presenting with pulsatile tinnitus and hearing loss, right? So this is characteristic of glomus tympanicum. A patient presents with dull aching pain and exacerbation during menstrual cycle, okay. So these were the MRI features. T1 hyperintense lesion, right, with no suppression on fat saturated images, right. So T2 weighted images show low signal with dark shading. What is your diagnosis, right? So guys, first of all, let us discuss what are the structures which appear hyperintense on T1 weighted images, okay. So one is your fat, which is going to appear hyperintense on T1, okay. But on fat saturated images, that is fat suppressed images, you will see anything which is bright on T1, okay, on fat saturated images. If it is fat, it is going to appear dark, right. Then your blood products, these are again going to appear bright on T1 weighted images, right, and they are going to appear bright on T1, right, bright on T1 weighted images and bright on fat saturated images, right. So these are two important structures which appear bright, right. And one was keratin, which we discussed in a patient with craniopharyngioma. Now guys, these are the T1 weighted images, right, and the structure is appearing bright on T1 weighted images. So it can be a fat containing lesion and it can be a blood containing lesion. So if I'm talking about fat containing lesion, it can be a dermoid cyst, right. But a fat containing lesion, it is going to show suppression. So in the question we have been already told to us that the lesion, okay, it is not showing any suppression on the fat. It means, okay, a dermoid cyst is ruled out, right. So dermoid cyst will suppress on fat suppression images because it contains fat. Now it can be a blood containing lesion, right? So a blood containing lesion showing you this characteristic T2 shading sign. Okay, T2 shading. This is seen in patients with T2 shading is seen in patients with endometrioma. Right? So what is T2 shading sign? Okay, the lesion is going to appear bright on T1 weighted images like this, and it is bright on T2 weighted images also, but not as bright as T2 weighted, as T1 weighted, right? The lesion is bright on T2 weighted images also, but it is not as bright as compared to the T1 weighted images. So this is known as T2 shading effect. And guys, this T2 shading effect, right, this is characteristically seen in patients with endometrioma, right? Now another simple question, a plain x-ray of the abdomen was shown to you. What you can see that there was calcification in the region of pancreas, so which is typical of chronic pancreatitis, right? So you should also know about the MRCP abdomen images finding of chronic pancreatitis. What you will see that pancreas will be atrophic, and you will see that the main pancreatic duct, it will be dilated on MRI abdomen images, right? So if I will be the examiner, I'm going to ask this question. So a patient has proteus infection, okay, now complaints of pain, okay, pain in the abdomen, and x-ray was done. A large stone was seen in the urinary bladder, okay. So which is the stone which is associated with proteus infection? It is your White stone, okay. It is a magnesium ammonium phosphate stone, okay. It can result in staghorn calculus within the renal pelvis, right? So this was more of a microbiology question, okay. A patient with acute pancreatitis was shown, has the following x-ray. What is your diagnosis? So on this x-ray we can see multiple inhomogeneous opacities, right, scattered in bilateral lung parenchyma. So these airspace opacities, this is in a patient with pancreatitis. These are seen in patients with acute respiratory distress failure, okay, syndrome, right, and also known as non-cardiogenic pulmonary edema. So in pulmonary edema you can get these airspace opacities, okay. So if I talk about congestive heart failure, okay, these opacities in the bilateral hilar region, okay, these are known as bat wing opacities, and these are seen when the pulmonary capillary wedge pressure, okay, it is more than 25 mm of Hg of mercury, right? Correct statement regarding esophageal foreign body. So first is a common sense thing. They are saying that right main bronchus is one of the site of constriction, okay. No, right main bronchus is not the site of constriction, okay. Most common site is cricopharyngeal, at the site of cricopharyngeus muscle. Yes, this is the most common site. This is the site of upper esophageal sphincter, which is a very common site, okay. So in the previous exam one sign was asked, that is your double ring sign, that can be seen in button battery. So question is very frequently asked on this foreign body within the esophagus, right? Not seen in the adults. Okay, it is not going to result in mediastinitis until and unless it results in perforation of the esophagus, right? So another question, a cystic lesion of the right adnexa with incomplete segmentation and cognitive pattern. Okay, so this incomplete septations with a cystic lesion in adnexa, this is characteristic of hydrosalpinx, right? So again, this was an MRCP image, and what can you see on this MRCP image, right, is that there was a fusiform dilatation of the common bile duct, right? So this fusiform dilatation of this common bile duct, this is seen in patients with choledochal cyst, right? In choledocholithiasis, what you will see that there will be dilatation of the CBD as well as there will be dilatation of intrahepatic biliary radicals. Okay, dilatation will be there, it will not be as dilated as shown in the current image. There will be dilatation of the CBD, there will be dilatation of the intrahepatic biliary radicals, and you will see hypointense filling defects in the esophagus, in the CBD, in patients with choledocholithiasis, right? In cholangiocarcinoma, right, you will see bilobar intrahepatic biliary radical dilatation. Okay, CBD can be normal or it can be narrowed, right? In primary sclerosing cholangitis, you will get a beaded appearance of the intrahepatic biliary radicals, right? So another patient with his history of road traffic accident, you can see there are multiple fractures involving the ribs, right? So pattern of breathing was asked. So this is the type of breathing pattern seen in patients with flail chest, right? This was a case of flail chest. Okay, two fractures, okay, in each rib involving 3 consecutive ribs, right? This is your flail chest. What you will see, paradoxical breathing, right? Small breathing, it is seen in patients with metabolic acidosis, right? So this was asked. So classical patient non-bilious vomiting, right? Ultrasound image of upper abdomen is shown. What you can see is that there is thickening of pylorus by more than 4 mm, extending for a length of more than 6 mm, right? Paradoxical aciduria can be given to you in the question on the X-ray. It shows a single bubble sign, right? So all these are typical findings of congenital hypertrophic pyloric stenosis. Ultrasound is the imaging modality of choice, right? So 2 questions were asked on the mediastinal masses, right? So guys, most common anterior mediastinal mass, right? So that is why most commons are important. So if you have no idea what is the mass, you could have gone for most common. So most common anterior mediastinal mass is thymoma. It is associated with myasthenia gravis, which was again a pointer given to you in the question itself, right? And what is the imaging appearance? You could see that there was a homogeneously enhancing lesion in the anterior mediastinum, right? So this was your thymoma. If you would have seen that the lesion was heterogeneously enhancing, right, there were necrotic areas within the lesion, then you could have thought of thymic carcinoma. Okay, you should also know the staging system for thymic carcinoma, which is your Mesoka staging system, right? Then if I talk about a fat containing lesion in the mediastinum with calcific areas in between, okay, fat containing lesion with calcific areas, this is a case of teratoma. Okay, so just remember the 4 T's of anterior mediastinal masses, that is teratoma, then you have thymoma, terrible lymphoma, and you have a thyroid mass. 4 T's of the anterior mediastinal lesions, right? Then you were given a CT aortogram image. What could you see on CT aortogram image was that there was a dilated aorta, ascending aorta or arch of aorta, right? So when do we call aorta as dilated? When ascending aorta is dilated by more than 5 cm, descending thoracic aorta by 4 cm, and abdominal aorta by more than 3 cm, right? So if the aorta is dilated by this much caliber, you are going to call it as a case of aortic aneurysm, right? Now another option that was there in the exam was aortic dissection. So in aortic dissection, what you are going to see? You are going to see that there will be an intimal flap. Okay, intimal flap will be seen, and along with that you will see 2 lumen. One will be a true lumen and the other will be a false lumen, right? False lumen and true lumen will be seen, okay, which will have different enhancement. So that is typical of aortic dissection, and these patients are going to present with a typical history of tearing, chest pain, right? So guys, these were few important questions that was asked in your NEET-PG 2024 exam, right? So now you all guys can chill out, you can go hang out with your friends, you can go out for trips and relax, right? Wait for the result. So a new chapter of your life is going to begin for some of the students, right? And some of the students may not even do well, okay? So those who are feeling कि भाई एग्ज़ाम का रिज़ल्ट कैसा रहेगा, क्या होगा, है ना, are still doubtful, I would advise you, लगे रहो, अभी भी पढ़ते रहो, don't give up, don't take a break, just take a break for 2-3 days और उसके बाद फिर से पढ़ना चालू कर दो और start preparing for the next exam, right? So bye bye guys, take care.